How to implant the Retropupillary Iris Claw IOL for aphakic eyes with no zonular or capsular support after cataract surgery. Arguably, the Retropupillary ICIOL can be preferred to anterior fixation. Why? There's no need to do a peripheral iridotomy. It mimics a PCIOL in the bag, and it's more aesthetically pleasing. It anatomically sits where the crystalline lens previously sat, and there's protection of the corneal endothelium. Remember to increase the power of the IOL if you're placing it posteriorly. For retropupillary placement, the manufacturer recommends an A constant for the SRK T formula of 116.9. If you place it in the prepupillary area, the A constant is 115.7, similar to ACIOLs. The Artisan ICIOLs are a rigid PMMA design with a 5.4mm optic, and they're 8.5mm in length. I've got 2 journal articles for you to read, and you can click on the links in the notes. The second one is a review of the surgical management and outcomes. They're both in 2021. It's easy to implant a retropupillary ICIOL. You can watch a video of Dr. El Shafi doing the procedure at the URL in your notes. And the steps are straightforward. It requires a full pars plana vitrectomy for the posterior placement of this lens. You need a large incision of 5.5mm. Make 2 paracenteses and then inject myocol into the anterior chamber. Remember to inject it over the surface of the iris, not through the pupil where it would just go straight into the vitreous. Check the IOL before implanting it that the cuts in the haptic, the claws, are patent. Then insert your ICIOL into the anterior chamber under viscoelastic and rotate it into the horizontal position. Suture your main wound at this stage to keep the AC stable. Then grasp the IOL with your microforceps and tuck one haptic under the iris. Use the special enclavation spatula through the side port and hold it in your non-dominant hand. Then the IOL should be tilted up against the posterior iris to visualize the claw configuration, and the enclavation can be made just by pressing on the iris tissue with the spatula. Add some more viscoelastic at this stage. Then grasp the forceps to tuck the opposing haptic underneath the iris, and then use the cannula through the paracentesis to enclavate the iris. It's just a tap with the cannula on the top of the break in the haptic. Then remove your viscoelastic and give intracameral antibiotics, and we're done.